Good morning to you all in Indonesia. I'd like to thank Jack News for giving me the opportunity of talking to you this morning. My name is David Blum. I'm from the NeuroMuscular Taping Institute in Rome, Italy. Let's go straight into the presentation. Okay, here we go. Okay. So I'd like to use the time that I have this morning with you to go through a very short introduction in neuromuscular taping. Neuromuscular taping is neuromuscular taping is a biomechanical treatment technique that consists in the application of an adhesive elastic tape over the skin surface. So we have to use the skin as our means of getting to our objectives, which could be the vascular system, the lymphatic system, the nervous system, muscle, joints, and ligaments. So when we apply a tape over the skin, our objective can be various levels. So a correct application methodology will assist in reducing pain, facilitating lymphatic drainage, blood circulation, and through the formation of the skin wrinkling, which is created from a decompression stimulus. So our objective when we apply a tape is to create a certain type of stimulus. So, and that is based upon how we apply. So it is a base methodology. In neuromuscular taping, we talk about a decompression stimulus. So as you see here, okay, this is a very old treatment application, which goes over 2,000 years ago. And so this is a ceramic base found in Italy some 25 years ago. And so this is a treatment, a bandage, a taping application in compression. And so the story is that this warrior has an arrow in the biceps muscle, and so consequently the arrow has been taken out. And so obviously what you apply is price, which means protection, rest, ice, compression, and elevation, exactly as you would do today if you went to a hospital with an arrow sticking out your biceps. But this is a compression technique, which means when you apply strips of tape, strips of bandage, etc., you are creating tension on that tape to create, obviously in this case, what is required in the acute phase is a compression sort of stimulus. Whereas neuromuscular taping is something different, which comes after an acute phase of trauma treatment, as we saw in the image just before. So this is a skin application, and it is in decompression. How can we see that it is in decompression? Because we see the tape has these wrinkles or undulations or convulsions. So as you see, this is 3 tapes over the lower lumbar area. And this is a typical application that we use for lumbar spinal conditions, which could be herniated disc or protruding disc or joint degeneration of the joint cartilage or stenosis, etc. So this is a particular application which only has 20 years of history, and it started in Italy with me 20 years ago in the beginning of 2000. So it is an obvious decompression application because you can see the wrinkles. In the previous slide, there was no wrinkles. Wrinkles was not created because obviously the objective is compression. So straight away, we can start to look at the taping applications that we see around us. We see it on television, we see it in newspaper, we see it on patients, and sometimes we understand, sometimes we don't understand. And so the first thing that we need to do is to look at the tape, see whether the tape is wrinkling. If the tape is wrinkling, it is creating decompression. If the tape is not wrinkling, it's creating compression. So this leads me straight to these 5 keys. These 5 keys will indicate whether the neuromuscular taping treatment is done correctly or whether it's not done correctly. So our first key is to look at the anatomy or the target area of treatment, which means we understand pretty well the anatomy, the functional anatomy of the body, whether it be muscular anatomy, skeletal anatomy, lymphatic, vascular, neurological pathways, etc. And so if the tape is applied over a target area which is considered necessary for that patient, then obviously we have to follow the anatomy that we see, that we know. Okay, the second aspect is the skin anatomy. So I know in medical science or across the field, skin is not really studied as muscular or other forms of anatomy. Skin is generally considered as something which is just covering the body, but we well are aware that skin anatomy has very particular aspects, especially for a neurological and proprioceptive point of view. So we have to understand the skin anatomy above our target anatomy, which means how the skin is and the lines of skin elasticity, because the skin has very specific lines of elasticity depending upon where you find it in the body. Skin elasticity over the fingers is only longitudinal, for example, whereas on the shoulder, the skin elasticity has a range of elasticity which corresponds to the range of movement that the shoulder has. So we need to have a complete understanding of skin physiology, lines of skin elasticity, and that range of skin elasticity, which is fundamental groundwork to a correct application of neuromuscular taping. Okay, so the third key is zero stretch. So when we apply a tape, neuromuscular taping concept is based upon zero tension, which means how do you apply an elastic tape and not stretch a tape? It is pretty easy to stretch a tape, okay? You don't really need training to understand how to stretch a tape because it comes naturally, okay? When you give an elastic band to anyone, the first thing they do is they stretch it. So in our trainings, the first obstacle we have in passing on the methodology is to pass on the concept of zero tension, okay? And zero tension, the ability not to stretch the tape, is really something that you have to learn, and it doesn't come naturally, okay? So the fourth aspect is the width of the tape. And so how the tape is cut, the width of the tape depends upon the depth of action that we're going to be dealing with, okay, which obviously depends upon our target. We're applying a tape for a specific purpose. It's a rehabilitation purpose. It's a treatment purpose. It's a proprioceptive. It's a sensorial purpose. We have a certain purpose for applying the tape, and we also have to understand the width of the tape to understand the depth of action. And the fifth key is the space between each one of the strips that we are applying. So each one of these 5 keys have a specific importance in the role of correct neuromuscular taping application. So our objectives can be variable. Okay, it depends upon what the patient's condition is, what the diagnosis is, what the pathology situation is, what is the actual problem that we need to treat at this point of time. Okay, so generally speaking, we can say that correct neuromuscular taping in decompression is going to reduce compression on pain receptors. So reducing the compression on pain receptors will have an immediate effect on the perception of pain and how that pain is felt by the patient. Okay, so another objective could be the normalization of muscle tension. And so the continuous treatment aspect of neuromuscular taping, which means we are going to apply the tape for a certain period of time, means it's going to have a continuous relaxation effect. It is going to facilitate lymphatic drainage, and at the same time, it's going to improve fluid exchange. So fluid exchange is that changeover of fluids from arterial and venous to venous capillary systems. It's also going to improve postural control and assist in joint alignment, etc. Okay, so there are many different objectives, and the objectives, I repeat, depends upon the patient. Okay, so as I was talking to, the fourth key is the depth of action. Okay, the width of the tape corresponds to the depth of action. So the tape is cut into various widths, from 5 to 1.5, etc., etc. So the wider the tape, the deeper the action, the narrower the tape, the more superficial the action. Okay. So the first skill that we have to learn is how to cut the tape. Okay, so we need to cut the tape as precise as possible and as quick as possible. So we're talking about a treatment tool. Neuromuscular taping is a therapeutic tool which we're going to apply in various situations to obtain certain effects. Okay, so the hypothesis is the width of the tape and the depth of action. So as you saw the application on the lower back area, so 3 tapes at 5 centimeters wide, and so that is applied over the lower back area. So that has a functional objective, which means the muscle fiber is tight, the joint spaces are compressed, the sciatic plexus is compressed. So consequently, we need to apply a tape with a certain width, which is going to work at a certain depth, which also corresponds to the type of muscle, fiber, and joint structure we have in that target area. Whereas when we are working at a sensorial and tactile level, we need to apply a tape which has very small width, so 3 millimeters, 4 millimeters, or 5 millimeters, which is an application which we could use for the orbicularis of the mouth, for example, to encourage correct opening and closing of the mouth during eating, for example, in a stroke patient who has difficulty or has a nose gastric sonda, for example. So we need to apply a tape, which is going to give a certain sensorial stimulus. Another example is with a patient with a neglect syndrome, stroke patient, where we have difficulty in the patient to recognize that the left side is there. So in that case, it's not a functional objective, it is a sensorial objective. So the tape is applied over the extensors and flexors of the hand at 3 millimeters, 4 millimeters, which means we're working at a very superficial skin level. So we also have the width, which is more effective at a lymphatic objective, which means between 8 millimeters and 1.25 centimeters, or a vascular level. So, for example, if we have a diabetic ulcer and we want to improve the body's healing capacity through improved oxygenation and fluid exchange in the area, means we are going to be using a vascular objective, which means between 5, 6, and 8 millimeters, depending upon the thickness of the skin in that area. So our objective is to encourage the wound healing capacity. Whereas if we have a painful neuropathy in a diabetic patient, in a large toe area, without the complication of a diabetic ulcer, in that case, we're going no longer in a vascular objective, but more sensorial and tactile objective, which means the tape is going to be 3, 4, or 5 millimeters to obtain the best result for that sort of condition. So when we talk about proprioception, as we know, is the ability to perceive and recognize the position of your body in the space around you. So the proprioception assumes a fundamental importance in a complex mechanism of movement control through mechanosensory feedback neurons found in the skin, muscles, tendons, and joints. So neuromuscular taping, when you talk about neuromuscular taping, we are talking about proprioception. Tape is applied on the skin, and our objective can be the skin itself or various levels below the skin. So let's just have a look at this. This is a stroke patient. This is immediately before and after, okay, video. So we have on the left side, the stroke patient, difficulty in the coordination of the movement of each one. The separate fingers is difficult to move in a more selective way, for example. Okay, and we are applying the tape. So here we have 5 strips, which are 1 centimeter. And so our objective here in this treatment is lymphatic drainage, blood circulation. And obviously it has also influence on the mobility of the fingers. So we can't separate one action from another, but we have to create a treatment objective based upon our evaluation and diagnosis of that patient in that point of time. So it's not just a question of just apply any sort of tape on the body and you'll get the result. No, it is a methodology based upon a diagnostic evaluation and application principle. Okay, so which means in proprioception and the information about any sort of limbs position or movement is not generated by individual receptors. It's not created by one receptor, which is giving the central nervous system all the information it requires. But it's by a population of afferents, which are all working together. So consequently, we have a tape applied over the skin, which is giving this multiple afferent input, which is referring to the CNS, okay, determining the location of the limbs in the space and determining whether it is safe to move or not. So it is a question of multiple afferent input, which is our key. So it's not just one group of muscle fiber, but it's the togetherness of different muscle fibers, plus skin over that muscle fiber or that target area, plus the tendon involved, plus the joint involved. So when we apply a neuromuscular tape, we are applying a tape over a selection of areas, which is going to create an improved postural positioning pattern and development during the movement of the patient. So it's that togetherness of different muscles, skin, joints working together. So this is a Parkinson's patient, okay, this is time 1, okay, hasn't been treated with tape before. And so this is his typical walking and postural control, slowing down in the end, okay, difficulty in the movement of the arms, the posture of the head is anterior. So this is the first treatment. So we're applying the tape over the posterior muscle chain, so the Achilles tendon, gastrocnemius, hamstrings, and anterior muscle chain, the anterior tibialis. And so only on the right side, because the patient refers problem major on the right side. So very quickly, we get a certain input improving the situation. So we add anterior neck fascia. So the patient has the right leg plus the anterior neck fascia. And so we see that the arms are now starting to swing in a more symmetrical, balanced way. The head posture is improved and he is walking much faster. He's walking much faster because he is feeling more secure in his movements. Now we add lumbar and abdominal. So this, we call this core stability. Core stability in neuromuscular taping means core mobility. So all of these applications are in decompression. And now you see he's swinging, he has more stability, he feels more secure in the movement, he's faster, and etc. So it's not just one application, it is the togetherness of various applications. So on your evaluation for that Parkinson's patient, you could have decided to start on the plantar fascia, and that is quite okay. You could have started on the spinal neck muscles, that is fine. But it is a question of creating a complex combination of applications, which is going to improve the overall condition of that patient, okay? In that Parkinson's patient, every muscle in his body is alterated, is modified by the Parkinson's condition. So we have to have, obviously in any disease state, we have primary objective, secondary objective, tertiary objective, etc. So the togetherness of applications is fundamental in a re-education concept of movement control. After a central nervous system or peripheral trauma, infection, and surgery, which means the patient knew how to walk before, now that he does not know, he or she does not know how to walk now. So our objective is that re-education of movement. So we're going to give clear input into certain muscle districts or muscle chains to help the patient coordinate the movement better. Or in the case of educating, which means in a patient who has central or peripheral conditions from birth, which means they don't know how to walk or don't know what is the correct positioning of a joint or the movement of the muscle, and etc. So we need to apply a tape with the objective of obviously creating that desired normal mobility. Okay. So an example is this. This is obviously skin tape undulation. So in this case, this is a child, 2 years old, due to a ischemic trauma and 8 days of coma. The child developed a severe head and neck dystonia, together with difficulties in breathing, vision, eating, etc., etc. Very complex situation. So the objectives here was the proprioception, re-education of neck muscles in the head and neck area, increased blood circulation, normalization of nerve endings, and proved that muscular or mechanosensory feedback, reducing pain. Obviously, she has pain, even though she doesn't say she has pain, and improve that postural control. So, as we know, the initiation of proprioception is in the periphery and not central. Consequently, the neuromuscular taping skin decompression stimulation creates that normalization. So when we talk about decompression through neuromuscular taping, we are talking about normalization action. So normalization of that stretching and contracting mechanisms when we apply it over the target area. So proprioception and neuromuscular taping is any activation of proprioceptors will modify how the central nervous system perceives where we are. We have to divide into positive proprioception, which means our ability to create clear treatment objectives and treatment combinations, which is going to support a functional anatomy to work better. Negative proprioception, okay, anything we apply over the skin is going to give a proprioceptive stimuli. So we need to create a positive one, different to a negative one. So tape skin undulations, okay, so in this case, the objective here is more lymphatic rather than movement orientated, because in this case, the patient is in coma. So our objective here is increase of blood circulation, reduce nerve endings compression, reducing pain, because we can understand that the patient does have pain through their breathing patterns, etc., and improve lymphatic drainage. Proprioceptors are also known as adequate stimuli receptors, which means they refer to a certain type and quantity of energy to which the sensory receptor responds, which means the quality of energy which that receptor receives will create the initiation of a sensory transduction. So it's not just that they are stimulated, but it is the quality of that stimulation, which means that the receptor will respond. So receptors, we're talking about three-dimensional receptors, not two-dimensional receptors, three-dimensional. So it is a certain mass, okay, which obviously can reflect on the compression or decompression, the elongation or the contraction, which that certain part of the body is receiving, which means through the skin, through the muscle, tendon, etc. So consequently, to create that adequate stimuli, okay, in pathological conditions, the major part of stimuli will be based upon decompression and not compression, because the receptors are in a stroke patient, in a Parkinson's patient, for example, are all suffering because they have excessive compression around and over the receptors giving the input. So we see a patient who is not moving normally, and that may be because of many reasons. So consequently, our objective is to create normality where the normality is missing. So the normality we have to see in a clinical situation is what is created by that dilation effect, which the neuromuscular taping is able to give. So where do I start? So in neurological disorders, okay, baseline reasoning has to be this, that we start superficial, which means we're starting at a sensorial level, vascular lymphatic level, before we get to deep applications which are functional or postural. So even though our objective is that postural control in a Parkinson's captocormic situation, our objective, or how do we get to that objective, must be based upon step-by-step application based upon your treatment objective. And so I advise to start superficially, make sure that the sensorial aspect, those togetherness of receptors are receiving an adequate stimuli to open the pathways, together with improved oxygenation and lymphatic drainage to the area. So, for example, this is a part of our projects in Africa. So it's clubfoot treatment project. We have several. And so this is a child. We have congenital clubfoot, so we have from birth situation. So we are applying the tape over what we see. What we see is the plantar flexors, plantar fascia is in retraction, the posterior muscle chain, tendon, Achilles tendon, gastrocnemius, soleus are all in contraction, hamstrings in contraction, together with the anterior tibialis and the extensors also in retraction. So consequently, we have all of this muscle fiber in contraction, which is pulling a foot, which is a combination of very small skeletal structures and many, many small joints. And so consequently, this soft joint structure is obviously being pulled into a inverted plantar flex position. So very quickly, what we have to do is to educate, because it's not re-education here, it's education of the foot to be in a more open position. And so when we talk about proprioception education here, we want that the child feels that the foot is, okay, sorry about that. Okay. Okay, so sorry about that. So the child feels that there is a proprioception education, which means we have to give input to the child, saying to the central nervous system that this is correct and this is not correct. So obviously we're doing it also to improve oxygenation to the area. A clubfoot situation is hot or cold. It is always cold, and because of the strong contraction of muscle and tendon fiber creating the compressed joints or multiple joints in the ankle and foot, we have many nerve endings which are in a compressed situation. So we have various objectives, and we start these treatments as soon as possible after birth. So a hypothesis of neuromuscular taping is based upon decompression. So when we talk about decompression, our objective is normalization of the pressure surrounding receptors at all four levels, which is skin, muscle, tendon, and joints. And so this is going to be the normalization, which is going to initiate that adequate stimuli missing in pathological situations. In a clinical situation, the togetherness of applications is the key to efficacy and protocol development. There is not just one treatment, but it is a togetherness of various treatments. This is also a post-traumatic situation, but the tape is applied for various objectives to reduce adhesion, improve blood circulation, etc. Okay, so neuromuscular taping key factors, excuse me, okay, is governed by various factors based upon a precise diagnosis, a complete psychomotor evaluation of the body of the patient. And so that creates a step-by-step treatment objective, which is going to create various treatment choices. So it's not just one treatment, but it's a combination of treatment choices. So when we're using neuromuscular taping as a part of this group of treatments that we're going to be using in that patient, we're going to be using the correct methodology of neuromuscular taping. So the correct combination of methodology, which is the decompression, it's not just putting a tape on, it's how you apply the tape is the key. And you will see the doctors and therapists who had best results really understand the methodology of what they are doing. So it is the correct combination of applications based upon where the patient is in that point of time. So we're treating the patient at this moment. We can have various objectives in the future, but we need to apply the tape and to evaluate, because the efficacy is immediate. Okay, so in medicine, okay, sometimes when we hear something like this, then we jump to conclusions and say it's magic or something like that. But efficacy is immediate. So means we always need to evaluate immediately before, immediately after. So a correct evaluation, correct treatment choice will always create an immediate positive modification. Does not mean that the patient is cured in one treatment, but it is, neuromuscular taping is one of those very few treatment tools that you have in neurology, which gives you an immediate feedback. And so based upon that immediate feedback, you are able to very quickly evaluate your diagnosis, your treatment objective, and to go forward. Okay, so efficacy is immediate. Okay, does not mean that this Parkinson's patient is going to be cured, but the mobility difficulty that she has in her hand, okay, with the coordination, with the movement, the freezing, the tremor, which influences her walking stability, is very quickly changed. It's immediately before, immediately after. So how long does it work for? Okay, so it's not, repeat, it's not magic treatment. So treatment is applied within a treatment program. So we want to give the patient improvement and to repeat those improvements over time. So there are some precautions and considerations, internal bleeding, infections, cancer, metastases, thrombosis, etc. These are all important precautions and contraindications for a tape which is used in decompression. With a tape used in compression, there is no real contraindication, but for a tape in decompression is okay. I want you to note pregnancy. Pregnancy is not an illness, but it is prohibited application of the abdominal area and over the spine area. All other applications of the muscle fiber is fine, but not over the abdominal area and spine. These are clearly indicated in our training courses. So how many applications, treatment cycles? Okay, according to the area to be treated, according to whether it is acute, post-acute, or functional phase. Usually an average cycle is 8 treatments treated bi-weekly. Longer term treatment cycles are going to assist in body functional and postural modifications, whereas short-term treatments per symptomatic treatments. Okay, so thank you again for your attention. Let me just get out of this. Okay, here I am. Thank you again for this opportunity just to create some clarification on neuromuscular taping. Taping all over the world is a little bit mystified. Neuromuscular taping is not mystic in any way. It is based upon clear scientific reasoning on pathological conditions, diagnosis, objectives, and studies in anatomy and how the body works. So thank you again. All the best. See you again when I'm in Indonesia. All the best. Bye.